Welcome to this SCG Health Give Me 15 Minutes education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. To help you spell my last name, the company is also called SCG Health. We opened our doors in 2011, and we focused our client services on revenue cycle management and strategic planning in this post-health reform world. This session will cover what you need to know about the life of a claim. This session, along with many others, are available for free as an archived video on YouTube. SCG Health also offers in-person conferences and many topics including ICD-10 preparedness, compliance, and EHR implementation. To learn more, check out scghealth.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact legal counsel if you have any questions regarding the federal and state law that apply to the concepts covered in this session. So with that, let's get started. So this is one of my favorite topics to go over. It is the life cycle. Truly, what is the life of a medical claim? If you were going to, grow arms and legs as a medical claim, what would you do? So to be honest, it starts at the patient scheduling. So a new patient or an established patient, whoever it is that calls in and says, you know what, I want to see a physician. That's when it starts, because you begin to get important information from the patient at that time. It's about their insurance, their name, their address, really important information. And as part of that, you're going to run an eligibility next, and that eligibility will give you information about the patient. So, for example, if they're not coming up, my guess is that they may have given you a nickname, for example, and that's why it's not validating. But information for a patient should be validated at least 3 days before the actual encounter and then the day of the encounter. And then once they walk in the door, you're going to have a patient registration process, and during that intake, you'll get additional information, which should include a copy of the patient identification card and a copy of photo identification. That actually comes out of best practices from something called the red flags rule, and it really gets at trying to prevent medical identity theft. So you'll then have the clinical encounter happen with the individual physician or non-physician practitioner, at which point they're either going to dictate, transcribe, or document in an electronic medical record what happened during the encounter. That then generates, either by them writing it down on a super bill or through the electronic medical record, identifies the codes for the services rendered and the diagnoses of the patient. So that super bill is then going to lead to claim generation. Once you have the codes and the information necessary, you can create the claim. And the claim, again, should include additional information such as, what happened with the patient, and again, the information that you received out of patient scheduling. It's either going to be auto-generated or rekeying, so it is an opportunity for error, especially if it's a handwritten super bill. I always wonder if I can read the clinician's handwriting correctly. That's going to be turned magically into an electronic data set. Now, the data set actually is something mandated under HIPAA. That's the Health Insurance and Portability and Accountability Act. It was an ancient law at this point, but it does actually establish the railroad tracks for how we speak electronically between health plans and providers. So here on this slide is some information about the individual electronic standards. And it is incredibly important that we use these because, if nothing else, it creates a predictable outcome for the life of a claim. Once the information is gathered, it needs to be communicated in a standardized way with health plans so that they can actually process the claim. Otherwise, it requires people, and that means it's going to take longer. There's a greater likelihood for error. The electronic standards are incredibly important. Now, they start with, if you recall, back when we were talking about doing the eligibility transaction, the 271 is the response that you get back from your inquiry, which is a 270. And the eligibility information is going to give not just the name, but also the deductible, how much of the deductible has been met, the coinsurance, and if they are CAQH certified, guess what? The course certification through CAQH does a bit more. And so you can get into copayment information for specific specialty information, such as a chiropractor or PT. It's really awesome how this is actually becoming a valuable transaction. The actual claim itself is known as the 837, and it comes in both an institutional and professional version. Professional is what we use in the medical office setting. The institutional is what is used in the facility setting, which may also be what we know as a UB form. The professional version on the paper form is the CMS 1500. The UB04 is the paper version of the electronic institutional version. And here again, it's going to be very straightforward. There's a lot of information about the patient and the provider, but it's going to have the date of the service. It's going to have the diagnosis, what services were performed by code, the charges, and that's how it's processed. Very straightforward. Now, the claim status is something that you send out after you submitted your claim electronically, and it validates that, yes, the health plan received it, and you should anticipate it taking some time for processing, usually anywhere from 14 to 21 days, and then payment will be made some point after that. Now, of course, I always make a caveat for Medicaid and workers' comp. It can be a lot longer than 14 to 21 days. What you get back after a claim is adjudicated is the 835. It's the electronic version of the explanation of benefits. And this is generated by the health plan, and it will include really important information, such as a claim number. The claim number is very important if you're going to appeal anything. It also is used to match back to the money that's received. You'll find out the date of the receipt by the health plan. They'll show you the services that were covered, the allowed amount, and the patient copay. But notably, the 835 includes something called CARCs and marks. And these are remittance and advice codes that come back to you about how the claim processed. It's very important when you start going in and doing your appeals and any of your revenue cycle management, figure out what's going on with those CARCs and marks. And I did cover those topics in another Give Me 15-minute education program. Now, the last thing that you'll get is when you get paid. Now, especially the federal government, and now it's about a federal mandate even for all health plans, they want you to do direct deposit, which is known as EFT, that is electronic funds transfer. And this is where the money is going to go into a specified account for a physician. And so you do have to go through a whole bunch of Patriot Act security aspects of your bank so that you can receive money. And just a quick note, most physicians are always worried, can they take money directly out of my account? Can they do an auto withdrawal? The answer is no. They can't withdraw money from your bank account. Once it's deposited, it's there. But they can do what's called a recoupment, and a recoupment comes out of monies that you are due. So let's say you have a check, and it's going to be for $100, but they mispaid you, in their opinion, $80, so they'll take that out of the check of $100 and pay you $20. So that's how they get their money back. They don't actually withdraw it out of your bank account. So some other things for you to know about the life of a claim is that let's go into what happens behind the curtain over at the health plan side. And this is the claim adjudication standpoint. So once your clearinghouse sends out, and that's usually your partner that you're working with to route the claim, and clearinghouses really act as a post office. Once the clearinghouse begins routing the claim, the health plan is going to receive the claim. And when they receive it, they actually can bounce it out, and that's called a rejection. If you get a rejection, for example, let's say the name doesn't match for the patient, or the information from you doesn't match what they have on file, they'll just bounce it out. They never truly received it, so you'll never get that acknowledgement that the claim was received. And so if you need to resubmit it, change the information and resubmit it, it's not going to be a duplicate claim. So I just want to clarify the difference between a rejection and a denial, because a denial means they've received it, and if you send it in again, it's just a duplicate claim. You have to change it and appeal it. So after they receive the claim, they're going to match it to the beneficiary. That's usually the first thing that is done. Now, every health plan is different on how they begin the processing. One plan starts with the zip code, which is fantastic. But again, they could start with beneficiary, they could start with the physician, they could start with the group, they could start with the tax identification number. They're going to start somewhere and begin processing the claim and making sure that it matches things that they have on record, both on the beneficiary side but also on the provider side. At that point, once they clear it for processing, they will process the claim. They first apply their proprietary claim edits. So this could include, and just for example, I love picking on them for Medicare, but a medically unlikely edit. So the removal of a 10th toe. That would be denied because most people have only 10 toes, so 11th toe would be a medically unlikely edit. So those have to be appealed because it requires human intervention. And most claims processing is done through auto processing and does not have a human involved, especially on the first time the claim goes through. after it goes through the claim edits, it will go through a coverage policy. And the coverage policy will double check that the services rendered for that type of physician and the specialty on file actually match what they are going to cover as medically necessary, and the diagnosis codes back that up. So it's always proprietary. Again, each of the health plans have their own coverage policies that hopefully are based upon evidence-based medicine. Then after that's all done and the claim is approved, they're going to match it to the contract. What is the agreed upon payment rate for those services for that individual provider? And this is oftentimes where you run into problems. If you're not on contract, meaning you're out of network, there's certain things that happen. It's adjusted to something called the actual, usual, and customary. But if you do have a contract, sometimes they're going to pay it wrong because, let's say, the name of the group is spelled a little differently, or the physician name is presented in a different way. So unless there's an exact match to the contract lines, you oftentimes will get paid not the rate you were expecting, which is why it's so important that you know your current fee schedule. Now, once it matches to the contract and the rate is identified, then the patient responsibility is figured out. Is it a flat coinsurance? Is deductible owed? Is it percentage? Whatever that is, patient responsibility will be identified along with the plan payment. They'll then send it back to the clearinghouse through that 835, that electronic explanation of benefits, and you can, again, get the response. And that will be followed up by the EFT. Now, a couple things I do want to highlight is that RTA, which is real-time adjudication, actually will do this entire adjudication aspect in 5 seconds. It's so super cool, and most of the health plans are doing this. Now, it will take a little bit different for you, either working with your clearinghouse and identifying who can do an RTA, because you can't do claims in batches. You have to do them individually, or you would have to file a claim on their web portals, on the health plan web portals. But you actually can adjudicate a claim and know exactly what the patient has to pay at the end of the service, so long as the super bill is completed. So I will say, really look at that as an option. It's a great way to change your revenue cycle, but also keep in mind that you may not get paid within 5 seconds. It's oftentimes going to be at your state mandate, or generally 21 to 30 days. So as I mentioned, what you get back is your 835. I talked about the CARCs and RARCs. I really am a big fan of those. Your EFT, definitely check out the trace number. The trace number on your electronic expense transfer is what you're going to match back to your electronic remittance advice, which is your electronic EOB. So make sure you do that. Now, auto-posting is where you can make this all work. Can your system actually match everything back and automate the approval through? Work with your clearinghouse, because they're the ones that are going to help you do this along with your practice management vendor. Now, billing, remember your patient responsibility, which I highlighted here is PTR. You need to know what that is, and of course you should be collecting as much of it as you can before the patient leaves the office, because once that money walks out the door, it's highly unlikely for you to pick back up. My only caveat is Medicare. Sometimes we don't know about secondary, so maybe for Medicare you don't do that. But for everyone else, you should be able, either through eligibility, real-time adjudication, or a reasonable estimate just of services, you can figure this out. So my other note for you on best practices is, please do make sure that there's someone who is double-checking that the money that has been promised to you from an EOB is deposited in the bank, because sometimes these are a couple dollars off and you have to go find where it went. So do make sure that that happens. Just an example, as I mentioned, the CMS 1500 is the pink form on your screen. That is the form that we know and love as our electronic version of the 837P for professional. The version that you should be using, if you do use paper forms, please make sure that you have the latest and greatest version that does include 12 slats for your ICD-10 codes. It's the 5010 version that allows you to do both ICD-9 and ICD-10 coding for your diagnosis, signs, and symptoms. Now, the explanation of benefits here is the black and white version that's all blocked up. It's just a sample for you for an individual patient, but it does give you an idea of how really difficult these things are to figure out. And I'm sure if you've looked at the electronic equivalent, oftentimes it's very hard to read. I will also note that on the paper version, it always seems to state this is not a bill. And that does confuse the patients, because if it's not a bill, then when your bill comes in, it does also look like a bill. They're supposed to pay that one, but not this one. Please, again, make sure that you educate your patients and tell them what to expect, but also move away from submitting paper bills to them. Instead, collect it at the time of service. So with that, I hope you enjoyed this presentation. For those of you watching the video archive, please remember to rate this video. To receive notices about upcoming Give Me 15-minute programs or other educational sessions from SCG Health, please sign up at scghealth.com. Thank you for joining me for this 15-minute education program. This concludes the presentation.